To the next topic, augmented renal clearance, where supranormal renal function can harm. Over to Dr. Asif Iqbal. CV. Dr. Asif Iqbal, Senior Consultant, Department of Respiratory Critical Care Medicine, Assistant Secretary, IMA Calcutta
I need
Branch,
slide changer.
Special Interest, ECMO and Extracorporeal Support.
Oh,
Over to Dr. Asif Iqbal.
converter. Back.
So he was also a part of our Nephro CM yesterday. He was involved quite
I have
extensively
sent
on
the
this.
slide.
So he has a special interest mainly on this augmented renal functions as well as on the RRT. So over to Asif. So till he gets rectified, so for the audience mainly, whenever we are initiating an RRT, so there is a subclassification of Kidigo has come when we are using a biomarkers. So earlier, whatever you have seen is one, then again it has been subdivided into 1S, 1A, 1B. So with the biomarker positive, biomarker negative. So in the subclassification, if they have two, and if it is biomarkers are high, and if it is worsening, as he mentioned, RRT needs to be initiated. So we will welcome Asif. Asif, are you ready?
So, good afternoon. I know this is the lunch session and I will not take your much more time. But augmented renal clearance, it is one of the neglected thing in ICU. And though it is not a new thing, it has been started research in 80s, then 90s, and there are a lot of paper. But this is one of the thing which is ignored, and nowadays, after the development of the targeted therapeutic drug monitoring, we understand the importance and the implication of the augmented renal clearance. And therefore, today we will discuss about the darker area, ignorable area. So the ARC first published in 2010, the definition is when their solute clearance, the GFR is more than the normal, like 130 ml per minute per 1.73 meter square, then it is called augmented renal clearance situation. And there are different stage: mild, moderate, severe, and very severe, is depending upon the GFR, creatinine clearance ratio. And so, why ARC is important? ARC is important because it enhances the clearance of the drugs, and especially important antibiotics, anticoagulant, and the anti-epileptic, and it reduces the therapeutic level. Therefore, there is a lot of treatment failure, and also for the antibiotic development of multi-drug resistant bugs. So, how common is ARC? ARC is the study showing that it is common in ICU patient, critically ill patient, 14 to 18%, and especially in the traumatic patient, especially in the neurotrauma, also burn, and the polytrauma patient, and those patients having going on inotropic support, and the younger age group. The more affected is the younger age group. Now, how we will diagnose ARC in our ICU? So it is difficult, challenging, but it is not like that, it is impossible. So there are certain parameters. The most important parameter is the glomerular filtration rate. And from the physiology first year, we know that inulin is the one of the marker for identify the glomerular filtration rate. And in a normal patient, we can use the creatinine as a marker. But remember, in an ICU patient, why it is challenges? Because there is all the equation which calculate the creatinine clearance, there has some underestimate GFR, because this is not normal physiology, there is an altered physiology when patient in a ICU. Though the creatinine clearance, one of the crude marker, we can use this one. There are certain scoring systems for high risk patient when you will understand this patient might develop ARC, so you can take better precaution those group of patient. One is the age criteria, other is SOFA criteria, and if it is a trauma patient, there are two scoring system. One is the ARC or ATIC for the trauma patient. Both the scoring have high sensitivity and high specificity, and both the scores showing that if the score is more than 6%, then it is a high risk for developing of ARC. Now question is here, why we are talking about ARC? How scoring is helped? So early recognition, identify the risk patient, obtain measure creatinine clearance, because this patient need creatinine clearance measurement frequently, and you can employ appropriate intervention, especially drug dosing, to prevent the your treatment failure. So implication already said, and when there is an augmented renal clearance, the most commonest effect on the drug, the pharmacokinetics of the drug has changed. So there are subtherapeutic concentration of the drug in the drug level, though we are giving the calculated dose, but it might be a subnormal dose for the patient in that situation, that is ultimately causing your treatment failure. So what is the mechanism of development of ARC? That is in single way called brain-kidney crosstalk. There are multiple mechanisms, but all the mechanism ultimately causing your hyperdynamic circulation, your increased cardiac output, increased renal blood flow, and it causing augmented renal clearance. So there are special population. One is the ICU patient and the younger pediatric population. ICU patient, there is a multiple risk factor for developing ARC, and the younger patient also there are certain risk factor. Now creatinine clearance is the estimated method and the ARC, and creatinine clearance till now is the gold standard. Now question is that whether we do creatinine clearance once daily, or we do not do, or we do more frequently. There are evidence showing that this paper is very old paper. Initially it was published that if you do 2 hourly creatinine clearance, it will give a good response. But you can early diagnosis the ARC. But the challenges is here, the workforce and the supervision. But subsequent trial has come and shows that if you do the frequent creatinine clearance, you can diagnose early your ARC, you can adjust the dose of the drug, especially in antibiotics, so you can prevent treatment failure. Now, the question is, can augmented renal clearance detected using estimated glomerular filtration rate? There are lot of debate, but as of now, we don't have other parameter to without the glomerular filtration rate to identify the ARC. Creatinine clearance is, as of now, is the only tool we have, and there are lot of calculation. But remember, all the calculation will give you estimated creatinine clearance, but actual creatinine clearance is not possible because of the physiological alteration. Now, what is the effect of ARC in our antibiotic therapy? We know that antibiotic work either is time dependent or it is a concentrated dependent. So it the BL-VLI or carbapenem is work on the time dependent manner if the minimal inhibitory concentration of the drug is is stay in the circulatory system more than your expected, more time. It will kill more bacteria. And there are some drugs like your vancomycin, your aminoglycoside. They work on the concentration dependent. If the drug is stay more concentration in a more than the MIC value, it works. But what our this ARC do the clearance of the drug early, therefore the therapeutic level is reduces. There are paper published in 2014 and subsequently 2017 also, that is augmented renal clearance in a septic patient, implication of the vancomycin doses. So this paper is done on the ICU population. They have taken 93 patients from the ICU, and most of the are critically ill, and among 40% is a septic and the septic shock. And there are two groups. One group is normal, and other group who's have the therapeutic. They are monitoring therapeutic drug level, both the group, and one group developed the ARC, and they have targeted daily vancomycin level 13.8 to 20, and MIC of the staff audience for vancomycin less than 1 microgram per ml. So what they found, and they have excluded those patients are on RRT, pregnancy, or this TDM less than time for dose less than 12 hours. So what they found because of the therapeutic drug monitoring, they found that the level of the plasma level, the drug is very less compared to those who do not have the ARC. And it takes time to reach the plasma level, at least 3 days for the good plasma level. So there are other paper also decreasing time achieving therapeutic drug level, and this nomogram also showing that if you do the creatinine clearance early and if you do the therapeutic monitoring, you can achieve earliest to your therapeutic concentration. So another paper, that is Alexander Jacob and his team, published in 2017, that is they have done this study on the same type of study on BL-VLI or your carbapenem, and they have taken 256 antibiotic measurement and 215 critically ill patient whose creatinine clearance more than 120. They have taken the patient on creatinine clearance more than 120 to this ARC group, and they do the therapeutic drug monitoring on this patient, and they have found that among the BL-VLI, the cefepime and ceftazidime has maximum effect on ARC. The therapeutic drug level is minimum in the cefepime and ceftazidime group compared to piperacillin or meropenem. And they have they have shown also in this study this subgroup of patients showing that 8 to 12 milligram meropenem per day needed for a patient who has established ARC need to maintain the therapeutic drug level. So that's the landmark paper which showing that what is the implication of the ARC when we are giving antibiotic unknowingly the ARC status of the patient. That is the main cause of the treatment failure. So there are other studies done by the Pearl and the Solander group. Study have reported influence beta-lactam concentration in critically ill patient where therapeutic drug monitoring can reduce insufficient drug concentration, and they have taken larger volume of patient, 1832 meropenem group and 636 piperacillin group, and they have seen that 39.3% meropenem group and 33.6% piperacillin group not
Asif, last
reaching
minute.
the therapeutic drug level. So they have given one the algorithm that if the the conclusion of the study, if the creatinine clearance less than 70, you can go for the usual dose, but if it's more than 100, then you have to increase the dose for both BLVLI and this piperacillin, your carbapenem. There are other paper also echoing the same. I'm not going to details. So what we will do and what we are learning from this ARC. So whenever we have a critically ill patient, we have to do risk scoring, and after risk scoring, those having the high risk development of ARC, we have to monitor the therapeutic drug level. If not possible, we have to do every day at least twice or thrice creatinine clearance, and we have to adjust the drug dose as per the requirement. And there are some suggestion of dosing adult. I'm not going to in detail due to time constraint. In summary, the augmented renal clearance is common phenomenon in critically ill patient, and it is more ignorance things, but and it is the most commonest cause of therapeutic failure, and especially for antibiotics, anticonvulsant, and the anticoagulant. We have to be cautious about the ARC. We have to calculate the creatinine clearance, and we have to act accordingly. Thank you for patience hearing.
Thank you, Asif, for the nice presentation.